Good morning, everybody. Great to see you. We've had some technical difficulties, but I believe they're solved now that our trusty companion Elise is here. Kristen just walked in. It's the full team, but as per usual, there's a bit of a crisis going on right now, which is really what we all deal with every day. So I'm super excited that Sean and I are here to talk to you today about Project Lifeline, which has been just an amazing, continues to be an amazing project. And we'll talk a little bit more about some very recent cases toward the end. The most exciting thing is the Maine Recovery Council just voted to support this with $80,000 over the next 2 years to support the efforts of this collaboration, really the ongoing work of the fire department and their mobile medical outreach team. Yeah, super excited. Next slide, please. So I'm just going to give you a brief background about, you all know this, but then Sean's going to talk a little bit more about the MMO team. So, we all know that the complexity of the substance use disorder epidemic, particularly amongst pregnant women, is worsening. The number of folks that we see that are unsheltered, unhoused, having multiple overdoses. We had 2 new patients enroll with us yesterday, one of whom was endorsing multiple overdoses per week and was asking about the effect that was having on her baby. So we're seeing a lot of overdoses. It's a major contributor to pregnancy-associated mortality in the U.S. It's increased overdose mortality amongst pregnant postpartum folks, and we believe, at least according to the data that we're looking at, as part of the maternal and fetal mortality review panel, which I serve on, that it may be a contributing factor into up to half of the maternal deaths in Maine, whether that's due to drug overdose or due to car accidents secondary to substance use disorder, or we see a lot of suicidality that is really secondary to untreated SUD as well. We certainly see a lot of complications beyond overdose, early deliveries, stillbirths, extended hospital stays for the mom-baby dyad. And the literature overwhelmingly supports that patient-centered multidisciplinary care for patients with SUD who are pregnant improves outcomes, reduces barriers. So yay, MaineMOM. I think the initial data, which we talked a little bit about, is so amazing in that we're seeing more positive outcomes amongst our MaineMOM population in terms of more full-term babies, not as many low birth weight babies as we see in other populations, yet the percentage of our moms that have many polysubstance use disorder diagnoses is much higher. So despite taking care of a much more complicated population, we're actually seeing even more positive outcomes. And so this partnership really came together because of several complex cases involving pregnant patients with substance use disorder in the greater Portland community. Some very difficult cases, particularly in the winter months where, women were sort of lost. We have a patient in the hospital today who's going to be discharged back to her tent at the end of her surgical procedure. And so there's just a lot of big complexities going on right now. And really for our team and also for the team of first responders, the EMS team that were dealing with these issues, it was very distressing for the collective group. And it became really apparent to me that we needed to have a system where we could really partner together, both work together side by side, but also be each other's point of contact. When they have a patient that they think needs treatment, they can refer into me. And when I need help following up on a patient who I can't find or I'm worried about, they're really able to do that really highly trained medical outreach into the community. So it's a super exciting partnership. I've only been on one slide and I've already talked too much, so I'm going to pass the baton to Sean. Next slide, please.
Sorry, I got to unmute there. Good afternoon, everybody, and thank you for allowing me to be here to talk about this. So just that couple of slides to introduce you to our program here in the fire department. We call it Mobile Medical Outreach, or MMO. Everyone just calls it MMO. It was kind of a brainchild of a multi-department series of meetings here in the city trying to address the rising overdose and opiate problem we were having in 2014-15. MMO launched in 2016. We've been through a few iterations. Initially, we were actually stationary in the shelter, and we were dealing directly with the shelter population, which had its benefits because we were almost like a little clinic to help them. But if someone wasn't in the shelter or was geographically anywhere else in the city, we couldn't reach them. And so we were talking about going mobile prior to COVID, but COVID really forced that issue because they had a big push to move people out of congregate living and into hotels. And so our population that we had relationships with and were helping were all over the place at that point. And so we did go mobile in 2019-20. So what we really need to focus on, and what we see, as Elaine mentioned, as first responders in the community, is we see a lot of people that struggle with these issues, with homelessness, with substance use. They're very complicated issues. And in our little slice of medicine, we don't really have long-term tools. Existentially, we're kind of around to deal with cardiac arrests and car crashes and fires and things that are very acute. And our toolbox is built so. And so, we are struggling with, as being people that want to help but don't have the tools to help. And that's where we started looking at more proactive and getting out to people, helping them with wounds, which obviously with injectables is a consistent battle. And as I just mentioned, our EMS system. So we can move to the next slide. Just the demand on our EMS system is significant with this population. There's our primary mission. It's to get out and like I said, our tools are limited, so we're trying to actually refer people into the right places to get all of these people the right kind of care, longer term care. One of those big foundational pieces is primary care in the medical system, right? Somebody existing sort of without a primary care physician, that's a very difficult position to be in life, and many small issues that could be handled when they're small can get much larger. Mental health obviously is a huge issue that we all face, and substance use. So again, our tools really don't meet any of those. We're much more acute. And then at the end of it, there is a benefit to the 911 system, that we're trying to maintain capacity for those more acute issues. And if a secondary benefit to getting people the right help also reduces demand for the 911 system, demand in the emergency departments, then that's a win-win for us. So, and ultimately we do participate in trying to house people. So I think Elaine just sort of mentioned it. My last point is one of the things to leverage with the fire department and EMS, our relationship with the community is pretty special, and we're out and we're in the community every day. We're talking to the community every day. Our relationship is such. And so Elaine just gave the example of, if she's trying to find somebody, we've got lots of people moving around through calls and through some, like the shelter, for instance. We might be there and we might be able to contact somebody that she's looking for. So we're really leveraging, it's a win-win here, where we're leveraging sort of our relationship with our community to be the eyes and the ears for the larger medical system and participate in that. You can go to the next slide for Elaine.
Great. Thank you. That's awesome. So what's Project Lifeline? It's a partnership between MaineMOM and the MMO team. We've been active for about a year. We were just chatting about that recently. I first worked with them in September 2023, so almost 15 months. The goal is really to reach patients earlier in the pregnancy, reduce complications, the risk of poor outcomes, ongoing kind of conversations in both directions. We initially provided some funding through the MaineMOM program, but as I said, we're really excited to get some funding through MRC. So our goal is to expand access to care, break down barriers, build trust with vulnerable, marginalized individuals. That's incredibly important. When the team walks in with their bright red paramedic t-shirts on, people are eager to talk to them, eager to be helped, eager to assist and communicate, even people who are in their own very difficult situation. And again, we want to reduce the unnecessary 911 transports, but also get the people that really need to be connected to care, connected to care. And again, really meeting people where they're at. I mean, this is a population that has difficulty coming in, don't always know when their appointments are, don't always have transportation, don't always want to come to the hospital. I mean, not everybody's had a great experience when they've been at the hospital. So it's an important component to meet them where they're at. We began with some enhanced OB education. So one of the attendings here, Dr. Dale, provided some education. We're working still on communication pathways, which I think is a constant effort to improve those, make sure that things are moving smoothly. All of our patients are MMC OB-GYN patients, and we practice in parallel. That's an important thing to understand. So like I have no direct oversight over the MMO team. So I practice sort of doing my own thing and they're sort of doing their own thing from a like legal orders perspective. But we are definitely working as a partnership for sure. But there is sort of a distinct kind of administrative structure. I work for Maine Health, Maine Medical Center, and they work for the fire department. Next slide, please. So we believe this is the first community paramedicine partnership in the U.S. that's specifically focused on pregnant and postpartum patients with substance use disorder. There is another partnership that is called Project Swaddle that's in Indiana that provides expanded prenatal care through community paramedicine. So it's in a very rural part of Indiana. I spoke with them to get their insight. It's quite different. It's really people who are probably more stable, they're more housed, they don't have SUD, but they live in a very rural area and it's kind of difficult to get to various appointments. So particularly like when you're worried about preeclampsia or something like that, they need a daily blood pressure check. That's a lot of what the community paramedics will go into the house and do. And they've done some follow-up studies on their project. Participants viewed the community paramedicine providers as a trusted provider, delivered accurate health information, support, and advocacy. They felt that their advice was non-judgmental and they were open-minded and wanted to help. And I can't express how consistent that is with the team that I work with, just super kind, friendly people who want to help. And again, they monitor critical situations, they facilitate communication, and they enhance connections to local resources. And really important, getting people primary care, getting people connected to housing. The other thing we've really been able to do is like in the moment, work with other outreach teams in the city of Portland. So a couple weeks ago, we were seeing a patient that was on the side of the road and she was picking up used needles and she had actually filled up 3 different sharps containers with needles. And we were able to call the syringe exchange in Portland to come down with a big bucket to remove all those needles. So just being able to sort of reach out to partners in the community as well. Next slide, please. So I ride at least twice a month. I'd love to go more. It's too many other things going on right now, but I go at least 2 Fridays a month. I actually bill home visits, which always feels weird to me that they're called home visits because usually they're on the side of the street in a tent or someplace that is not actually what you would picture as a home, but it's an offsite visit. They're actually, you bill pretty high because the complexities of the social situation are such that it makes it a very high acuity visit just by the nature of the fact that they're living in a tent. We have a lot of bi-directional handoffs. So this is the mobile outreach van we ride around in. It effectively has almost an exam room in the back, not in the traditional sense of like a bed, but like bench seats where you can bring people in. This was really important when we brought a patient in last Friday from the cold, because really being able to do an assessment in a warm location was really important, and it was private. You know, there was other people around and we could I sat in the back with the patient and 2 paramedics while she was being assessed. And it was, you know, people who were around didn't need to hear the whole story. So this is a picture, the first time I rode with the team, just, you know, visiting the tent communities where there were more tent communities and just seeing, you know, meeting people where they're at. Next slide, please. So I love this work. It's incredibly fun to work with other just incredibly compassionate, dedicated individuals with this sort of shared goal of improving care for those that are really the most vulnerable among us. It's been motivating, inspiring, delightful. We have great humor. I just really enjoy the days that I get to spend with these folks. And for me as a clinician on the street, or as a clinician caring for people, being able to see what's going on the street is actually incredibly important, just because it helps me. I've learned so much from them in terms of providing care in whatever environment you find yourself in, whether it's 20 below zero or, you know, cars racing by. I mean, the ability to sort of understand how to serve people in really complex, like physically complex situations has been very insightful for me. What's really nice is that we have a lot of partnerships like transportation, like outreach, but this is the only partnership we have that actually has highly trained medical professionals. So when we really need the answer to, please tell me that blood pressure is okay, does that person have a fever today? This is the group that we can really lean on to provide that information. And as I said before, my primary goal starting this project was that patients would feel that I was like invading their space. Like, what are you doing out here when I'm supposed to come to the hospital to see you? But it's actually entirely opposite. People are incredibly grateful that I'm out there. I think it just sends a message that I really care about them if I'm willing to kind of meet them in the park or in a tent or wherever we are. And it has actually created relationships that's been able to bring people in because they I see them the first couple times with the MMO, and then we're able to get them into the clinic eventually, which is always the goal. But I'll provide care on the street as long as they need me to, really, because that's what's the right thing for them. Next slide, please. Okay, so this is like 2 recent cases. So I went out with the MMO team on Friday. We had a patient that was supposed to have surgery. She no-showed for her surgery, and she has a complication that puts her at high risk for, she needs surgery for something that puts her at high risk for significant complications. We'll put it that way. And one of the challenges, because they're not letting the tent communities kind of proliferate the way they did in the past, is that tents get tagged very quickly if people have to move. So like the picture to the right is the tent she lived in previous to the one that she's in now. So there's a lot of kind of abandoned tents. You don't know if people are in there. You knock on the tent, but should you open the tent if people don't say anything? How do you determine whether somebody who might be dead in there? How do you do it in a safe way? You know, those sorts of things. So what the picture on the right doesn't capture is the wind that was coming off, because we were right next to a body of water near the airport, and the wind that was certainly making it below 0 from a wind chill factor. It was only like 20 degrees in the regular air temp. So we were, and we're asking other people in the community, where do you know this patient or this person? And because there's a lot of knowledge amongst the community members that are living in the sort of unhoused population. And so looking for tents, we probably spent 25 minutes, and eventually one of the paramedics found the tent we were looking for this patient. And, when we found her in her tent, she looked very, very sick. And we were able to kind of get her out of the tent, get her into the back of the mobile medical outreach team. I talked to the ED attending and the OB attending. We were able to kind of get her the care that she needed. And just really, really important. And then they could do follow-up care with her as well. But the picture on the left is the team that I was out with. So the 3 people in the front are 3 paramedics, and then the 2 people walking in the back work for the City of Portland Mobile Outreach Team. And again, they can actually transport patients, whereas the MMO vehicle right now cannot transport patients. And so we're able to work as a team to get people where they need to go. And so that was an incredible success to be able to get connected to that patient and get her the surgical care that she needed. And then yesterday we were in the clinic and the MMO team called me, and I thought they were calling me about the patient in the tent, but they were actually calling me about a different patient, which is that they were at this Riverside shelter, which is a large shelter in Portland for folks who are unhoused, and they ended up identifying a person who was pregnant, using fentanyl, and had had some recent overdoses. And they were able to call me, and I said, "Oh, sure, we'll provide care." And so the team sent an Uber to the Riverside shelter. They drove her to our clinic. We had her on meds literally in less than 90 minutes it's probably less than 60 minutes, but we'll go with 90. But from call to her exiting with an appointment with an OB provider tomorrow, all the pieces that she needs. And just, again, the relationship they were able to develop, because that team identifies somebody in the community that needs care, calls us, and then we're able to really do that bi-directional handoff is so critically important. And now they know that patient. We do have them sign releases so that we can communicate with each other. So we have them sign release that I work with the fire department. So it does allow for that bit of communication. But just critically important work, and just incredibly rewarding work to be able to really help people real time like that. So that's just in the last 48 hours this has been, or maybe 72 hours. This is 2 really important cases, and there's so many other ones. There's a couple other success stories here, but oftentimes it's really being able to reach people too that don't have phones, don't have minutes on their phones, don't have voicemail. So the particular patient that was living in the tent to the right didn't know about the surgery, because again, our system doesn't work. If you need surgery, you have, people can call your cell phone, they can call your home phone, they can leave messages about where you need to be, when you need to be there. If you don't have that and somebody says, "Oh, we're going to schedule your surgery," we'll get in touch with you when it's booked, right? That doesn't work with this population. And so you really need to be able to meet them where they're at, give them the information that they need, support them, answer their questions, just be present with them, and they're scared. But the complexity, patients are still living in tents. We don't have a lot of space in the shelters. Sometimes people are, kicked out of the shelters. There's an interesting article in the paper yesterday about a gentleman who's been kicked out of the shelter for a year because of behavioral issues. There's no, if those you have not been to the Riverside shelter, it's a wonderful facility, but the men and the women are entirely separate. There's no opportunity for sort of couples to be together. So it's for a lot of people, the structure doesn't work for them for a lot of different reasons. And so we do still have a lot of people that are living in tents. And because we're moving them so much to not create these tent communities, which I certainly understand why we're doing that, but it does make it actually a lot more difficult to find folks because they move from here to there. And that's, again, where the Portland outreach, where the other outreach teams really can come together and say, this is a patient we're looking for. Do you know where that person is? And again, we don't share why we're looking for them, but we're able to sort of say, this is somebody that we're looking for. Okay, Sean, any parting thoughts from you? I talk too much, as you know, but we don't hear you, Sean.
Uh-oh. Well, can't hear me right now.
You're a little quiet, but we can hear you.
I'm not quite sure. I always like to throw a couple of things in. Is it coming through or no? It's good. Okay. The work that we're doing is very much outside of what a normal fire department would do, and that was really, really good for our organization. And so I always try to push that narrative to anyone who's listening about your particular view on the world may be very different than ours, but by looking, through a different perspective and working with Elaine, it really, and then it ultimately is opening up funding streams for us as well that are outside of fire department funding streams. So there's like real value in getting outside your box. And this is an example of it. And to Elaine's point, one of the amazing things for me, I've been involved in the program for about 5 years. I never actually worked the program as a provider. I've just been the administrator running it. The resiliency change that I see in my people that work in the program, switching from reactive. If you think about a 911 call, it is generally generated by somebody else than the caller, right? Maybe, but in this instance, an overdose, it's going to be generated by someone else. We show up with at least 2 trucks with our lights on. We jump off, right? There's a big show. The person maybe never even really wanted our help. And we show up, and if you think about, they may be on the ground and we're standing, and there's just there's a lot of room for that entire situation to fail. And when we switch to proactive, and this is part of the special relationship, we just meet them where they're at and ask how we can help. And it helps the patients, but it actually really helped the resiliency of the people that work in the program because they know they're helping. And then when they go on 911, they have that relationship to leverage, right? They already recognize each other and there's a level of trust. And that's been an amazing piece that I never really saw coming, was that both the patients react better and the providers react better. It's a situation where they're primed for success versus one that they're primed for failure.